All right, so good afternoon. I'm not sure how many people are on this webinar. I know most people are back to work and to in some degree or form. But hopefully this will be recorded and you'll be able to see it a little bit later. Well, it's 6:30 a.m. here in California. Sun's not out yet, but it's about to. So it's a nice start to my day. We get on to see patients at about 8:30. So we've got about an hour and a half. So Paul asked me today to talk about graftless solutions. And many of you may know that as all on 4, all on 6, or whatever you may call it. Essentially, what we're going to be addressing today is full arch fixed implant rehabilitation without having to use any type of bone grafting. And when we talk about this, things have developed over the last, I would say, 10 years as far as this treatment concept is concerned. But there are quite a lot of misconceptions about this treatment concept. And these misconceptions are really a result of, I would say, manufacturer promotion and the thought that this process is easy and anybody can do it. So I will try and address those. So I want to start with this particular slide, and I'm not sure how many of you have read this particular book. I actually read it during our lockdown. It's a magnificent book, and it's Man's Search for Meaning by Viktor Frankl. Viktor Frankl is a Holocaust survivor. He was in Auschwitz, and he tells the story of his struggle in the concentration camps. And we've been going through a lot of struggle, I would say, over the last 3 months. Things have hit us in a way which we never anticipated. And despite that, Viktor Frankl, would tell you that there is a meaning in all of this. Viktor Frankl was somebody, they did absolutely everything you can imagine in the concentration camp. And the way he got through it was through the strength of his mind and being able to find a meaning in regards to why it was happening to him. And without that mindset, he probably wouldn't have made it. So with that said, I'm sure despite this last 3 months and despite the struggle and despite the questions dentists are asking themselves, how are we going to get back despite the negativity and the media and what have you, I'm certain that all of us will get back, and all of us will get back a little bit stronger than we used to be, and we'll be able to take care of our patients in the best way possible. So just a little bit of background on me. I'm from London. I trained at the University of Manchester at the dental school, and I graduated in 1993. And it seems a long time ago. And I moved to London after my vocational training, and I decided just to join private practice. I did my vocational training actually in Derbyshire, and I moved to private practice in London. And I was quite fortunate that I joined an independent practice, meaning that we saw very few patients on the health service. And that was a good and a bad thing. The good thing was that we were able to charge the fees that we thought were appropriate. The bad thing was that now I had to deliver. And in my first year in private practice, I realized what I didn't know. And it really kind of opened my eyes. I used to remember patients coming in and they needed 8 to 10 units of crown and bridge work. And before I would just jump in and get it done and not know what the outcome was. And I dread to think, how many patients I left where I honestly didn't know what I was doing. And with that said, in those days, 1994, I was looking to do some type of course, some type of additional training that would enhance my skill set. And I stumbled across Paul Tipton, and I've known Paul now for the last, I would say, 25 years. We've been in touch back and forth. And Paul really introduced me to what is possible. I used to visit his practice up in St. Anne's Square in Manchester, And, with a group of about, 8 to 10 other dentists, we used to, at least once a month, he used to do some presentations and show us, what he used to do. And I used to always think, I wish I could do that. So I would tell you that Paul probably, he doesn't know it himself. He probably was one of the people who pushed me into further training. And as a result of that course, I decided to pursue things across the pond at the University of Southern California. And at the University of Southern California, I completed 3 years, and they were a great 3 years. And once again, I finished. And once again, you think you know everything, but you find out very, very quickly that that was just the start. And 25 years on now, I'm still learning every day. And there's all those patients that present where, I think to myself, okay, what are we going to do here? So I am in full-time private practice. I enjoy treating patients on a day-to-day basis. I'm 1 day at the university. My job at the university is to do the literature review for the residents. And whatever you see today, to some degree, we're going to present literature to support what we do on a day-to-day basis. The other hat that I do wear is that we do have an organization here in Los Angeles called the Digital Dentistry Institute, and we have a program globally in Australia, Dubai, even UK. We were there last year doing a full arch program in London, which was very well attended, and the hope was that we were going to get back there this June, but unfortunately that didn't materialize. But we're looking at getting back there in 2021. We hope to see you there also. A lot of the information that you're about to see, we have published. We did publish something in 2006, which was an introductory guide to treatment planning and implant dentistry, and some full arch was covered. But we found that when we were talking about graftless solutions, there really wasn't a systematic approach in regards to how do we treatment plan? How do we do the lab work? What is the maintenance? There are so many unanswered questions. So, I decided a few years back to get together some of the world's best authorities in full arch implant rehabilitation. And, I'm fortunate enough that I was able to collaborate with quite a few people to be able to put this text together to at least help dentists walk through treatment and diagnosis and execution of these types of treatment plans. So in the short time we have here today, we're going to be talking about graftless solutions. We're going to be talking about myths and realities. We're going to be talking about what is dogma and what is actually science. And everything that you see today is in real-time private practice. This presentation hasn't been put together just to photograph, certain patients. This is literally in between patients. We are taking pictures and we're getting things ready. So I apologize, if some of the pictures are not so great. Hopefully you'll understand. So let's start talking about treatment planning. And when we talk about treatment planning as dentists, we often look at an evidence base. Every meeting I go to, somebody says, what's the evidence for this? What's the evidence for that? And I'm going to tell you, in reality, in dentistry, we really don't have much evidence for a lot of the things we do. And I'm going to give you a perfect example. When we start talking about CAD/CAM dentistry, framework design, how much evidence base do we have for these titanium frameworks, the zirconia frameworks, the PEEK frameworks? And the reality is we don't have much evidence base. And the reason why is technology is progressing at such a rapid pace, it's difficult to keep up. So what do we do when there is no evidence base? Obviously, common sense takes us a long way, but also the clinical experience of others. We look at people who have done this type of work for many, many years, and we ask them what worked in your practice, what didn't work, why did you think it worked? So if you find something that is new in the market, my suggestion to you would be, don't do a lot of it. Maybe do 1 or 2 cases and see how things go. But look at your colleagues who have been doing these procedures for years and years and years and gain some, useful information from them. So the first question I start with is, what is All-on-4? And if you were to read a lot of the company brochures, a lot of the magazines, the lab protocols, they would tell you it's about 4 implants. It's about 2 anterior implants that are straight, 2 posterior ones that are angled, and it's a full arch fixed provisional that is immediately loaded. I will tell you it's a graftless solution. It's a way to give a patient teeth literally the same day you're extracting their teeth without having to undergo bone grafting. Now, one of the things I have seen as I have traveled and gone to various symposiums is that even patients with a ton of bone, they've been given an All-on-4. The All-on-4 treatment concept was designed for a specific type of indication. It's designed for situations where the sinuses are pneumatized, there's no posterior bone, and we are tilting the distal implants parallel to the anterior wall of the sinus, where there is posterior mandibular resorption, and we're unable to place implants posteriorly. So it's not really designed for those types of situations where the patient has a ton of bone. If they have a lot of bone, you can place 6, 8 implants. Now, what is the advantage of placing more implants? The advantage of placing more implants is obviously you can segment the prosthesis, and you're able to break it up into smaller sections, which becomes easier to manage should there be a complication. So just remember that the All-on-4 treatment protocol has been designed, as I said, with a specific indication in mind. Now, over the years, we've been doing graftless protocols for the best part of, I'd say, 15 to 20 years. So we do have a lot of data. We have seen complications. We have experienced things not going so well. But the more we do, and the more that I see that is done, and the more retreatments we do, I often see a lot of things which are perpetuated by symposia, perpetuated in the literature, which aren't really true. And these are the myths that pertain to graftless solutions. So let's start with the first one. One of the myths of graftless solutions is that it requires aggressive bone reduction and pink prosthetics. Any brochure that you read pertaining to All-on-4 or All-on-6, you're going to see tooth and pink prosthetics, and more than likely you're going to see an acrylic titanium restoration. Now, this is how things were done, and I'm not saying you don't do this, but there has to be an indication for doing this. So let's have a look at what I'm talking about. So this is an example of a surgeon removing bone, and some of you looking at it are probably thinking, "Oh my goodness, look at how much bone is removed." And the surgeon will remove this and be very proud that they've removed this whole chunk of bone. And to be honest, I've made this mistake. In our earlier days, we did used to do quite significant bone reduction at times. And I often ask myself, was that necessary? And the question that I ask you is that, say you reduced a lot of bone, and say that patient was that 1 in 1,000 where all the implants fail. How would you retreat the patient? And that is something that you have to start thinking about, because a lot of patients, and I would say even dentists, think is once we remove teeth and we place implants, that prosthesis is there forever. Well, I have some information for you that definitely does not last forever. We do have literature pertaining to the fact that if the implants pass the first 5 years of service and they are maintained well, the implants should last a long time. And the original Brannemark implants were in place in the patient for 50 years plus. However, the prosthesis did have some wear and tear, and the prosthesis had to be replaced 3 times in that patient's life. So before you start removing a lot of bone, you have to ask yourself, is it really necessary? And I'm going to give you some indications of when bone reduction is required. So let's take a look at this example here. This patient presents to us failing maxillary dentition. She's had splinted crown and bridgework in her maxilla, and she's looking for a solution. Now, when you see teeth like this, I will be the first one to tell you that teeth are better than implants, and that goes without saying. In terms of the signaling it sends to the soft tissue, we always prefer to keep teeth. And even if it's a little bit harder to do, there's a lot of value in maintaining teeth. Now, sometimes we are faced with situations we are unable to maintain teeth, and we have to treatment plan accordingly. So this patient presented to us failing dentition, maxillary arch, and we start looking at the mandibular anterior teeth, and the mandibular anterior teeth are over-erupted. And you can see here that we have posterior mandibular resorption, over-erupted mandibular anterior teeth. We have crown and bridgework, which is not the best in the world. So we go to our diagnosis, and our diagnosis is key. We can all agree to treatment plan differently, but the diagnosis has to be the same. So our diagnosis is lack of posterior support, caries underneath restorations, over-erupted mandibular incisors, and posterior mandibular resorption. So there are a couple of ways that treatment can go. And one way is to remove the maxillary and see the restorability of these teeth. And if these teeth are indeed restorable, there is every chance that we could do endodontics, we could do sinus lifting in the maxilla, we could place implants posteriorly and have a combination of crowns and implant crowns, and there's absolutely nothing wrong with that. And in the mandible, we can do posterior grafting, we can place implants, we can use those implants for orthodontic anchorage to intrude the mandibular anterior teeth, and there are a number of things that we can do to correct the occlusal plane and decrease the vertical overlap and provide the patient with posterior support. And once again, there's nothing wrong with that at all. The other option, should the circumstances dictate, is to perform a graftless procedure. So if you look at this particular patient, the sinuses are pneumatized. We cannot place implants posterior to the premolars. We have posterior mandibular resorption where the nerve is a little bit further up. So this would be an ideal scenario for a graftless procedure. Now, what dictates what we do? There are a number of things which dictate what we do. And I would tell you, patient desires, often patients come in and they say, this is what I want. But as a clinician, we have to make that decision for the patient, meaning that we have to give them the best advice in regards to what can be done. Cost certainly dictates what we're going to do, simplicity of the procedure, and more importantly, health history. Our particular patient here was on multiple medications. There was a lot of recurrent caries underneath the existing crown and bridgework. And when we looked at all of her medications and the fact that she was xerostomic, the decision was made, rather than to save teeth, we made the decision to remove teeth. If there was not caries, if the caries was not too extensive underneath the crown and bridgework, if the patient was not xerostomic, we would have made every effort to maintain her existing teeth and do the primary treatment plan, which was to try and keep the teeth together with reestablishing posterior support through dental implants. So when you look at that type of patient, you have to ask yourself, is it necessary to remove bone to do a graftless procedure? Is it the right thing to do? Would you remove 5 to 6 millimeters of bone to get that ideal pink prosthetics appearance? And I would argue that really you shouldn't. So what we do here is a tooth-only graftless procedure whereby we are looking at the defect. And the defect really, once we extract the teeth, is only teeth. So we only really need to replace teeth. Now in the mandible, we are going to have to reduce a little bit of bone, because the mandibular anterior teeth have over-erupted. And when they over-erupt, they bring the bone with it. And the bone they bring with it is quite thin. And you can see the position of the mandibular anterior teeth in any complete denture textbook. That will tell you that that mandibular incisal edge position is not appropriate. So we have to start thinking about how we're going to develop anterior guidance, how we're going to develop the biomechanics of the anterior teeth, so that we can provide a patient with, not just good looking teeth, but teeth which are going to provide some longevity. So we do have to actually reduce the bone to lower the level of the incisal edge. And that's our indication in the mandible on when you see pink prosthetics. So how do we start the case? We start the case, we can either make conventional impressions, or we can digitally scan. We can make a conventional analog surgical guide, or we can have a printed surgical guide. The goal being trying to give the surgeon the final tooth position from which the implants are to be placed. We get the provisional ready, and once again, this can be analog injected, or it can be milled or printed. So these are our provisional restorations. I'm ready for the immediate load procedure, providing that the primary stability of the implants is appropriate. So one thing in this particular process which becomes very, very critical is the three-dimensional positioning of the implant, both mesiodistally and also apicocoronally. And the reason I say that, the depth of the implant has to be worked out, because we are going to be placing pre-angled abutments or multi-unit abutments on them. So we have to place the implants depth appropriately, but also mesiodistally, we have to be sure that the implants are not positioned interproximally. If they're positioned interproximally and you are designing a zirconia-based restoration, that area of the restoration will be quite weak. So it's critical that the implants are placed three-dimensionally appropriately. We fabricate our provisional restorations, and our provisional restorations are reinforced with a fiber, and we create overt pontics to go into the extraction sockets to try and make things look as nice as possible. So the question becomes, is the papilla going to stay there forever? I don't think so, but we can compensate for that with a longer contact area, developing some chroma interproximally to give the illusion of papilla. We all know that when you have multiple implants and a long span, it's tough to develop ideal soft tissue in terms of interproximal papilla, even between the pontic sites, but we try our best. So this is our definitive restoration. You're going to have to excuse the California white, as they say, but do we have interproximal papilla? We don't. We just have a long contact point. The patient has a thick biotype, and we've been able to sculpt the tissue to make it look decent. And this was our radiograph. So you can see we tilted the implant placement. And this was our starting situation, provisional restoration, and our definitive restoration. And you can see in the mandible, we did have some pink prosthetics. And as I said, the reason for that was that we were lowering the mandibular incisal edge level. And due to the over-eruption of the teeth, the bone there was non-usable. It was too thin. So we had to recontour the bone so we had a sufficient thickness of bone to be able to place those implants. And this is our patient. This is 5 years post-op, and things are holding up pretty well, and the patient's quite happy with the end result. So questions, will it be stable? I can tell you we have about 8 to 9 years data on it. All the patients that we have seen, the soft tissue has remained stable. Saying that, we have chosen patients with a thick biotype, and also those patients who have a short lip. If you look at the lip length and they have a short lip and they smile and you see a lot of gingiva, those are the type of patients where we do tooth-only crown and bridge work in these types of patients. And the reason for that is when they smile big, and if they're showing pink prosthetics, it never looks very good. It's, if you can imagine those types of patients where you're fabricating dentures and the patient smiles and you see pink, it never looks, that good. There are also alternative strategies, the partial extraction therapies, whereby we are able to root bank to maintain bone in the pontic sites. And, that is something that has been done for years, and it's been one of the strategies we've utilized in partially edentulous patients also, where we're trying to maintain bone and trying to not create, but trying to maintain the existing soft tissue. The question I have is, what do you have to lose by keeping bone? So say, for example, this particular patient, the implants were to fail, we could still easily retreat this patient. Imagine you'd reduced a lot of bone and then all the implants fail. How would you get back in there and retreat that patient? One of the questions we're often asked is, doesn't this type of provisional restoration break, because you don't have that thickness of, the pink and the white to reinforce the restoration? In our experience, yes, we've had a couple here and there fracture. We have reinforced it with a silane coated fiber. We do make it thicker on the lingual part. And we reinforce patient instructions, meaning that, please maintain a soft diet. And we make that key in the overall approach. And when we're doing that, we have found that patients have maintained their restorations quite well without breakage. So you have to ask yourself, what are we missing? Are we missing tooth? Are we missing tooth, gingiva, and bone? What type of defect do we have? And more importantly, do we really need to reduce bone? Now, we do have restorations with pink prosthetics, and you're going to see some in this presentation, but there needs to be a reason why you are removing bone. Now, one of the reasons could be that you want to hide the transition zone. So for example, when the patient smiles and you have gingiva showing and the patient says, listen, I really don't like the fact that my gingiva is showing, we would reduce bone to hide that transition zone. Another reason to reduce bone is to improve the emergence profile. We want to have a nice emergence profile that the patient can clean. We do not want to have a horizontal shelf. So improving the emergence profile to improve the hygiene of the patient is another reason. We definitely do need to have an adequate volume of bone. Often you see this periodontally involved patients where the teeth have over-erupted and the teeth bring the bone with it. And the bone where the teeth have over-erupted is very, very thin, almost triangular shaped. And we have to reduce the apex of the triangle so that we have an adequate thickness of bone to be able to place implants. And finally, restorative space. Depending on the type of restoration you're doing, will dictate the space that is required. For example, acrylic titanium restorations need about 15 millimeters of space minimally from the head of the implant to the incisal edge in the anterior area. And this is one of the reasons I would tell you that over the years, we do not use acrylic resin titanium for maxillary restorations. Few reasons, actually. One of the reasons is we don't want to unnecessarily reduce bone. 2, acrylic resin titanium really doesn't look great over the years. 3, it wears down very, very quickly. 4, teeth do tend to come off and teeth delaminate and it becomes an emergency. So to try and avoid those types of problems, our protocol has been not to use acrylic resin titanium restorations, definitely in the maxilla. So myth 1, it requires aggressive bone reduction in pink prosthetics. Not true. You don't reduce bone unless you have a specific reason to. So the next question, the provisional is not important. How many times have you been told by somebody, a previous instructor, never make the patient a good provisional because the patient's never going to come back? And I hear it, I've heard it in the UK, I've heard it in the US, all over the world. And I sometimes ask myself, why do instructors even say anything like that? Why would we not want to make the patient a good provisional? The provisional is our business card. Really, it's the first opportunity to show the patient what you're able to do. So the provisional is key as far as I'm concerned. So when we start looking at situations like this, here we have implants in 1-2 and 2-1. And you can see the obvious soft tissue discrepancy. Things don't look great. And if this patient was managed with provisional restorations to develop the soft tissue, we may be in a much better position. Here obviously we have discrepancy in the mesiodistal width of the teeth. You can see 2-1 mesiodistally is wider than 1-1, and the laterals are not really that symmetrical, but we can manipulate the transitional line angles and characterize and manipulate the soft tissue so that we can make them look similar. So these are our provisionals that we use to sculpt the tissue, to get patient acceptance, and to be able to deliver restorations which resemble teeth and that resemble the other side. By no means is this a perfect result, but it's a better result than what the patient came in with. We've been able to address the patient complaints, and we couldn't have done this without the use of provisional restoration. So as everybody knows, provisional restorations give us, biological, aesthetic, and mechanical. It has to satisfy those requirements. And provisionals and full arch implant supported restorations are no different. Often, people often tell me that, oh, it's just a temporary. It's really not just a temporary. The more time you spend in the provisional restoration, the less work you're going to have to do in the definitive restorations. And one of the protocols we run in our practice is that we spend a lot of time fabricating a provisional restoration, and literally once the implants have integrated, we have a 2 or a 3-step protocol where the patient can go directly to the definitive restorations. Now, when we're looking at the provisional restorations, the provisional in full arch restorations, full arch implant supported restorations must satisfy certain requirements, just like any type of provisional. To reduce fluid entrapment, cleansable contours, we're able to develop the patient's speech, we're able to develop patient's tissue contours. So when you see situations like this, you often ask yourself, how does this happen? How can we develop concave contours and expect the patient to be able to clean the restoration? This certainly is not something that is ideal and something that the patient's able to maintain long term. So we definitely want a nice, highly polished undersurface, which could be flat or convex. And we have to satisfy the requirements in terms of aesthetics, phonetics, developing tissue contours. The tissue contours have to be concave so that the restoration contours are convex. It's similar to, say, for example, developing an ovate pontic when we're doing a 3-unit bridge. The ovate pontic extends into the socket, and this is quite similar. We are adding acrylic in our provisional restoration to sculpt the undersurface of the restoration. And this is our definitive restoration. We want to have a nice convex surface, and if you are using zirconia-based restorations, the fit surface after glazing definitely has to be hand polished if we are going to make use of the biological enhancements of the zirconia restorations, meaning that if we're going to get a hemidesmosomal attachment to the zirconia, it has to be hand polished, because a glazed surface, although it looks smooth to the eye, is actually not a very smooth surface. And just to give you an example, this was a patient who presented to our office, and you can see how angry the tissue looks, and you can see how red and inflamed it is. And the reason for that is that the tissue surface is just rough, it's concave, and just after removing some acrylic and adding some acrylic and improving the shape, this is a week later, and you can see how you can impact the tissue health just by the contours of your restoration. So now I'm going to show you one of my mistakes. This is something that we did, I would say now 13 years ago. This gentleman came to us. He'd been wearing removable partial dentures for many, many years. We diagnosed him with having lack of posterior support, and the patient did not want to go through a grafting procedure. And you start looking at the teeth. You start looking, are these savable? What can you do? And you look at the radiographs, and maybe some of you may look at this and say, hey, I'm going to save the teeth. And, I don't disagree. Maybe you can. But here you can see pneumatized sinuses. You can see some pathology in the right sinus. This has to be cleared up before we do any type of implant treatment. And you see a significant amount of bone loss for this particular patient. Patient has an abundance of bone in the mandibular arch, but not so much bone in the maxillary arch. So the question now becomes, do we graft the patient? Do we wait? Do we do sinus lifts, augment, place additional implants? And yes, that certainly is a possibility. But once again, once we involve the patient, we give them the options. The patient does not want to go through multiple visits. And you can see how much bone we have available. So we have to create inter-arch space. And in this particular patient, we decided to use zygomatic implants for posterior support. 4 implants were placed anteriorly, and I'm going to tell you there's really no reason. We could have just placed 2. In the mandible, unfortunately, we did do bone reduction to do pink prosthetics. As I said, we've made those mistakes also, but we tilted the implants. In the mandible, it's quite easy to place 6 implants in this patient and break that restoration up. But we made that mistake in those days. And this was our provisional restoration. And at the end of a very, very long day, we delivered this. And we were patting ourselves on the back, and we were quite happy with things and what have you. We sent the patient home. And that evening, 9 p.m., the patient's wife calls me. And she says, "What on earth have you done to my husband?" I was like, "What are you talking about?" She goes, "I can't believe the way you've made him look. It doesn't look like him. These teeth just are not the same." And at that point, my ego at that time took a hit, and I thought to myself, what is this lady talking about? Did she even see her husband's teeth before we started, like the condition they were in? And now he has, a beautiful, bright white smile, and your typical, I would say, Hollywood, straight appearance. And what is she talking about? And time like that, there's no point in arguing. I said to her, "Okay, give me a couple of weeks, and then we will see what we can do. If you just don't mind, just wait for him to heal, tissues to be less sore, so that I can remove the prosthesis and see what we can do." So he went from here to here, and when I look at it, yes, there is a significant improvement, but when I look at it closely, no, the provisionals really are not as good as they could be. So I decided to remake the patient's provisionals. So we took the existing provisionals off, we made impressions, and we made the patient a new set of provisionals. This is one of the advantages of restoring at abutment level. You're able to remove the prosthesis on and off without impacting the bone implant interface. In the earlier days when we used to immediate load direct to the fixture level, and based on some good research by doctors Tarnow and Worley, essentially we were told not to remove the restoration for 3 months. At multi-unit abutment level, you can remove the restoration as many times as you want. So we fabricated the provisional restorations, and we delivered the provisional restorations, and the patient was ecstatic, and also his wife, more importantly, was also ecstatic. And when I compare how the patient started to the initial provisional that we had delivered to the second provisional we had delivered, I can tell you, I can see the difference. And maybe I can see now why the patient's wife was not so happy in regards to the initial outcome. So myth number 2, the provisional is not important. I will tell you, the provisional dictates everything. Anything in restorative dentistry, your provisional is a precursor of your final restoration. I know in some countries around the world, when they are doing this particular treatment protocol, they are delivering the definitive restoration the same day or the next day. In my humble opinion, that's a mistake because you haven't had a chance to test your solution. Okay, the third myth, the titanium framework and individual crowns is the best restorative solution. So I'm sure many of you have seen this restorative solution on Facebook, on Instagram, at some major symposia. And I'm going to tell you my experience with this type of restoration and give you an idea of when I would use it and when I wouldn't use it. But I found that everybody was talking about this at some point, and everybody was telling dentists that, listen, this is the type of restoration you need to do, and this is the best solution, and the individual crowns, if something breaks, you can replace a single crown, and all of that. And, you know, let's address some of the pluses and the negatives of this type of restorations. So this type of restoration, what it is, it's a CAD-CAM titanium bar with titanium and non-visible surfaces. It has lingual notches posteriorly, so if you needed to remove the crowns, you could do PFMs or, you know, zirconia restorations here. Layered zirconia anteriorly and pink composite to replace the tissue. Now, we did these types of restorations, and this is one of the first types of restorations of this kind that we did. And, you know, we were quite happy with the end result, but little did I know what was in store for me later down the line. So on day one, it looks fantastic, but I think one of the definitions of success is how does it perform over a period of time? So I'm going to tell you, despite what anybody else says, that you are going to get chipping of the composite resin. Should you choose to use acrylic resin instead of composite, you can be assured that that acrylic will not look so great over a period of time. The aesthetics of the composite resin is going to deteriorate over a period of time. And once again, no matter what anybody tells you, and they say to you, listen, if the composite chips or fractures, you can easily, you know, rebond it in the mouth. You can easily add to it. I can tell you with composite resin, if it's been in the mouth a significant period of time, to bond to it is really, really hard. Definitely in my hands, and, you know, maybe some of you can do it. And also to get a perfect color match is tough. Because we are cementing the crowns, you are going to get leakage and staining at the gingival margins. Is the leakage going to matter? Probably not. But the staining is something that the patient may complain about. Often these types of restorations are used when the screw axis trajectory is not in an ideal position. So essentially what you're doing is you are cementing these crowns over these, you know, titanium preps, so as to say, where the screw axis hole is to hide that screw axis hole so that the screw axis hole doesn't show through the buccal surface of the tooth. So we are cementing all of these crowns into place. So the question I ask you is, say for example, the patient has a problem with one of the implants or some issue which necessitates you removing the restoration. Can you imagine how long it's going to take you to remove the crowns, dismantle this restoration just to evaluate it? So maintenance appointments would be, you know, quite laborious, and to handle complications becomes quite difficult. And the last thing would be the cost of the restoration. You know, I have high respect for laboratory technicians, and they deserve every penny that they work for. And we have, you know, 4 technicians on our on-site laboratory, and we work very close hand in hand. But the cost of these types of restorations are significant, so to say. So do I do this type of design? Yes, I do. I think the individual crowns on preps is a design that can be utilized. It does give you what we call ideal aesthetics because it gives you true separation between the teeth. When would I use this design? I would use this design where the access holes are in an ideal position, meaning that they are lingual to the preps, so that you can unscrew the whole restoration should you want to without having to touch the teeth. I would do it on a zirconia or a cobalt chrome framework so that I can lay a pink ceramics which will hold up over a period of time. The crowns will be cemented outside the mouth. Once again, the pink ceramics will not deteriorate over time, and it will provide you with the best aesthetic result, knowing that this is going to be quite a costly lab fee, but this fee is passed on to the patient. So if the patient comes in and says, I want the absolute ultimate in aesthetics, and they've lost, you know, white and pink tissue, this is the approach that I would go for. And, you know, the laboratory technician would be very well compensated as we would be charging the fee to the patient. So the titanium framework and individual crowns, is it the best restorative solution? No, it's not the best restorative solution. I don't like the titanium framework and the pink composite combination to start, but I will say that it's a great solution when the access holes are in the correct position and the correct material combination is used. Next question, occlusion is specific and scientific. So when we address occlusion, we're going to address occlusion as far as the immediate load restoration is concerned, but also some aspects of the definitive restoration also. So as far as the immediate load restoration is concerned, there is really no good literature telling you what type of occlusion you should put on your immediate load restoration. So what I'm going to present right now is not evidence-based. It's based on thousands of arches that have been done, not just in our practice, but in practices of colleagues, globally, and sharing results with each other. So as far as biomechanics of the immediate load restoration is concerned, definitely we want a good AP distribution of implants. We want no premature contacts when the patient bites down. Everything touches, no interferences in lateral excursion. We want contact from canine to canine and shim stock drag posteriorly, and it's going to be a screw retained acrylic restoration with no cantilever. Now, some of you are wondering, why on earth are you putting contact just on the anterior teeth? Aren't the anterior teeth going to break? So I'm going to give you my rationale of why we do that. So if I was to ask you a couple of questions, where is the weaker quality bone and where is the increasing occlusal load? So the weaker quality bone is definitely posteriorly, right? Posterior maxilla, posterior mandible. And the increasing occlusal load is definitely posteriorly, nearer the jaw joint. So that's one of the reasons molars are bigger than incisors, because they are designed to withstand load. So with that in mind, we are focusing all the load towards the anterior part of the mouth from canine to canine. And the reason for that is the patient is unable to put so much force on these teeth. And our goal in the immediate load phase is so that the patient cannot eat hard foods. So we're forcing them to chew with their anterior teeth. They can't eat the wider variety of foods. The load is less and the restoration is less likely to break. Now, some of you may be sitting there and saying, hey, that sounds all fair and well, but what about a class 2 situation? When the patient has a skeletal class 2, how do you manage that? If it's not a severe class 2, we build an acrylic ramp lingual to the maxillary anterior teeth, and the patient occludes on this acrylic ramp. Now, some of you may say, hey, what about a severe class 2? What do you do in those types of situations? Well, in those types of situations, all bets are off. You're going to try and provide occlusal contact over as many teeth as you possibly can. And that's one of the reasons why I'm telling you there's no evidence base over here. So that's for the immediate load restoration. Now, when you go to the definitive restoration, things obviously change a little bit. So now we're going to talk a little bit about implant occlusion for full arches. And the question becomes, what do we really know about that? I see so many chapters written in textbooks and people's opinions, but the reality is, if we look at it from a scientific perspective, we really don't have a very strong evidence base for implant occlusion. Most of the things that we read are dogma, it's people's opinions. Really, there is no solid science behind it. Now, why is it so difficult to develop a scientifically based occlusal scheme for an implant-supported full arch restoration? The occlusion is based on many, many things. First and foremost, biomechanical design of the implant, the number of implants that we are using, nature of the opposing dentition, the design and fit of the prosthesis, the material of the prosthesis, the deformation of the supporting bone. There are so many factors that we have to consider. It's really tough designing a study to show superiority of one occlusal scheme over another, to show that one occlusal scheme is much more efficient than another, whether patients prefer one occlusal scheme over another. So these are the challenges that we face. So most of the things that we see in textbooks, in articles, in presentations are really dogma, things that have been perpetuated over the years without question. Most of it is expert opinion, and once again, I will tell you that we listen. We listen to the experts who have done it over many, many years. And if we don't have science, as I said, if we don't have an evidence base, expert opinion is a secondary that we can acquire some information from. A lot of the studies have been in vitro studies and animal studies. And a lot of the information we get is extrapolation from natural teeth. And we have to realize that natural teeth have a periodontal ligament. Implants do not. Can we truly extrapolate? I don't think we can. So there's no definitive scientific studies to show if canine guidance is better than group function, or if lingualized balance is better, whether one type of tooth form is better than another, whether one type of occlusal scheme is preferred by patients, or if one type of occlusal scheme is more efficient. So I'm going to tell you what I do. I do canine guidance. And you're probably wondering, why on earth would you even say that? Wouldn't you want to distribute the load over as many teeth as possible and do group function? The reason I do canine guidance is purely mechanical. When the canines go in guidance, the posterior teeth disclude. So the closer the teeth are towards the jaw joint, the less load I want on them. Now, should the canines wear, it goes into progressive group function. So that's the occlusal scheme that we espouse to. The next, I would say, myth that is perpetuated is that a lot of the textbooks tell you that you have to load the implant down the long axis of the implant. And axial loading is very, very important. So the question I ask you, when the patient starts eating food, is that load down the long axis of the implant? Absolutely not, right? And if axial loading was true, how can you explain the success of graftless procedures, zygomatic implants, pterygoid implants? Now, single tooth implants, we try best way possible to fabricate the crown contours so that we have a chance of loading down the long axis of the tooth, saying that we don't want to cantilever off of a single tooth if we can avoid it. But in full arch situations, we know that axial loading really is just theoretical. Now, excessive occlusal load. Often I read many of these papers and it says that excessive occlusal load can cause bone loss and can cause you to lose the implant in itself. Really, there's no studies to show that. There's really no definition of what constitutes excessive occlusal load, meaning that an implant in the anterior part of the mouth versus an implant in the posterior part of the mouth, the same load, one may be excessive and one may not be excessive. It will depend definitely on the design of the implant and also the nature of the bone, the quality of the bone. So, defining excessive occlusal load is quite, it's questionable. And I would tell you that excessive occlusal load does not lead to loss of integration, and that's not my opinion. There are some studies to show that. However, excessive occlusal load can lead to prosthetic problems, but we don't see those problems in splinted situations, believe it or not. So mechanical complications can occur. You can get prosthetic screw fracture, you can get fracture of the tooth, you can get loosening of an abutment. So these are the mechanical complications that can occur, but we haven't seen failure of the implant in regards to excessive occlusal load. Now, what are the mechanical issues that are related to occlusion? Definitely accelerated wear. We can get chipping and fracture of ceramic. We can get wear of the acrylic resin restoration. And it's important to talk with your patient and discuss these problems before you start, because patients, when they come in and they're getting this type of work done, obviously it does cost a fair amount. And we have to communicate to the patient that, listen, this is not something that's going to last forever. I see so many patients who come in who've been told that they need all their teeth removed and implants placed, and the reason they're doing it is because they're never going to have a problem again. Absolutely not true. Implants come with their fair share of problems, as teeth do. So if the patient is indicated to have this type of restoration, we have to discuss these problems ahead of time. Now, why do these mechanical complications occur? implants, are not teeth. You do not have that perception, that feel from implants as you do from teeth. And osseoperception is not as good as proprioception. And patients who are bruxers definitely will cause you some problems. And the prosthesis, for sure will not last forever, and the patient should know this. So when we start looking at occlusal materials, there are a ton of occlusal materials out there. Sometimes it can get quite confusing which type of occlusal material that you should use. In the initial restorations, which Professor Brannemark talked about, he used gold framers with acrylic teeth, and he used that as the reason he used that was for the damping effect of the acrylic resin. It almost substituted for a periodontal ligament. Now, was there any evidence base for that? Absolutely not. Over the years, we've used porcelain fused to metal restorations. We have, today we have ceramic restorations, whether it be layered with feldspathic ceramic, whether it be lithium disilicate or zirconia restorations. We have monolithic restorations, which are performing actually very, very well. However, we don't have long-term data on them. I will tell you, based on everything that I have read, there doesn't appear to be a difference in the strain that is transmitted based on the different types of material that are used. I will tell you, acrylic resin will wear a lot more than zirconia or lithium disilicate. And that is not a complication, really. It's a consequence of the material. We can expect this to happen. Ceramic fractures can be as high as 20.3%. If your framework is not designed well, if you're using zirconia, minimally layered zirconia, where the ceramic is supported, literally all the way to the incisal edge, will reduce your ceramic fractures. And once again, monolithic materials, they are nice, but we really don't have as much information on them as we like. So occlusal scheme be? My goal here is not to confuse everybody and try and say do whatever you want. We have to give you some type of guidelines. But there are a lot of things which influence the occlusal scheme, and I wanted you to be aware of that. Now, with that said, what do we do as far as occlusion is concerned? So in a static occlusion, we try to minimize the vertical overlap. And the only reason we're trying to minimize the vertical overlap is so we're trying to biomechanically improve the situation. If we have a very steep vertical overlap, the patient is likely to exert more load on the anterior teeth. This could result in chipping, wear, fracture of the teeth. So we're going to develop a shallow guidance, but that shallow guidance is going to be sufficient to provide posterior disclusion. And we do exactly what we were taught in dental school. We fabricate the provisional, we test drive the guidance, we develop an incisal guide table, we communicate that information to our laboratory technician, and the laboratory technician reproduces that guidance. Static occlusion, posterior teeth are going to have even simultaneous contact all the way up to the premolar. If we are cantilevering, our preference is not to put any load on the cantilever. So the cantilever, when we test with shim stock, I would have 4, 5, 6 shim stock drag straight through so that we do not have any excessive load on the cantilever. As far as dynamic occlusion is concerned, our preference has been canine guidance. If the canine is to wear, it wears into unilateral group function. The goal is for posterior disclusion and no non-working side interferences. So how do we deal with bruxers? These patients are the toughest to treat. So in bruxers, whatever you do, you're going to have a complication. If they can do this to their teeth, any prosthetic material that you use doesn't stand a chance, and the patient has to know that from the outset. So in patients like this, mutually protected occlusion with canine guidance, limited use of cantilever, these are the type of patients I would over-engineer it. This is the type of patients I would use the 6 or 8 implants and segment the restoration so that I can deal with restorations simply. If I'm doing, say, for example, a graftless procedure, I'm going to look at the materials that I'm going to use. So in the maxilla, I would use zirconia. in the mandible, I would use acrylic resin titanium. And the reason for that is I'm using a hard material against a soft material. And what I tell the patient, you're going to wear out your lower teeth. I don't want to use rigid versus rigid because of the possibility that it may impact, the implants. May, I say. I don't have any evidence for that. There have been, quite a few studies out now that, zirconia against zirconia works very, very well. But I'm looking at complication management. So if I have zirconia against acrylic resin titanium, it's relatively easy to replace the teeth on an acrylic resin titanium restoration. For sure, we're going to do a screw retained restoration. We're going to provide the patient with a protective occlusal device. Once again, no scientific evidence for that. And we may consider Botox in the patient's temporalis and masseter muscles. And the reason for that is just to reduce the power that they can exert. Patient education, lifelong maintenance. And you cannot eliminate the possibility of a sleep-related breathing disorder. All of these patients that come to see us with attrition, erosion, we have to suspect, once we've done our evaluations, we have to rule out the possibility of a sleep-related breathing disorder. So we do send these patients for sleep studies to get tested, because if you don't address that aspect, they're just going to destroy what you put in their mouth. So as far as occlusion is concerned, posterior support, no contact on the cantilever, centric relation and maximum intercuspation, at the time of restoration, they are coincident. We know that will change over time. We plan a moderate guidance. We test it in the provisional, and we provide the patient with a nighttime appliance. Now, one thing that I've incorporated in my practice over the years, when I incorporate technology in our practice, we wait on the sidelines, we wait for other people to use it first, and then we incorporate technology. So the last 25 years, I've been using shim stock and very thin film articulating paper, and I still use that today. But one additional piece of armamentarium that we've really incorporated in our practice is something called a T-scan. And I know, it is, I would say, controversial, but I will tell you how we use this particular instrumentation. So what T-scan is a digital occlusal sensor system whereby you get a pictorial representation in the form of a bar graph to show you the intensity of occlusal contact. So there's a thin film of a digital paper, which gets put in a holder, you put it in the patient's mouth, and you ask the patient to bite down, and you get this pictorial representation. And the color and the height of these bars will dictate to you the intensity of the occlusal contact and where you may need to adjust. So if I was to ask you which mark is the most forceful, A, B, C, or D, I'm sure most of you, without the bat of an eyelid, would say C. And the reason why we would all say C is that we have a bullseye there, right? And at dental school, they taught us where there's a bullseye, there's excessive occlusal contact, and we adjust that. So in this instance, it wasn't C, it was actually A. So if we had adjusted C, we would have had much more contact on A. And we could develop some symptoms on A. So the way we use T-scan is we adjust with articulating paper and shim stock. We use that as our verification. But another added layer of protection is the T-scan. The T-scan picks up things which we may have missed, especially when we're marking ceramics. Zirconia, definitely in a wet environment, is very hard to mark. So the T-scan gives us an additional layer of protection. So all of our cases get finished with the T-scan. So occlusion, myth number 4, occlusion is specific and scientific. I would say no, it's not scientific. We have, in fact, very little science with implant occlusion, and we should just adhere to good biomechanical principles. So the next myth that is perpetuated over a period of time is that we have science for cantilever length. Let's find out if that is true or not. Okay, so with our more contemporary materials, I shouldn't really say contemporary because zirconia has been around for the last 10 years at least. How much can you cantilever? How much can you cantilever in the maxilla? How much can you cantilever in the mandible? And how do you avoid this type of scenario, where you've got an adequate thickness of zirconia and it broke? What are our guidelines? What can we use to deliver restorations which can stand the test of time? So as far as cantilever is concerned, everybody will tell you biomechanically, the length of the cantilever has a much more significant impact negatively on the overall restoration than does the number of implants. So if you look at an example like this, where the AP spread of the implants is not great, you can see we have a massive cantilever and something is going to give, whether it be a restoration, whether it be a prosthetic screw, but something is going to give there. So when we start to look at the articles, the literature on cantilever length, we know that, as far as cantilever length is concerned, it's 1.5 to maybe 2 to 2.5 times the AP spread. And these are the guidelines that have been given to us. And these guidelines are all based on mathematical models. They're based on people's opinions. And there's really no science behind it. What we do know is that the more we increase the cantilever, the more deflection we will have, all right? So, and it has a very significant impact on that. And the thinner the framework, the more deflection we will have. So, we all know that cantilevers are detrimental to restoration, so we're going to try and minimize the cantilever as much as possible. So I tried to look at a lot of the literature as far as cantilevers is concerned. And honestly, the literature wasn't that strong. Essentially, most of the articles, they compared cantilevers more or less than 15 millimeters. And the reason for 15 millimeters is 15 millimeters is, on average, is the mesiodistal width of 2 premolars. What the article stated was that when you have a cantilever above 15 millimeters, they had greater prosthetic survival rate. And when you had greater prosthetic survival rate, and with more than 15 millimeters, there were more prosthetic complications. And we do know that, studies in the maxilla are not, there are not many studies in the maxilla as far as cantilever length is concerned. Now, some of you may have been to presentations where you've seen restorations which have a 3-tooth cantilever. And the speaker on the podium says, hey, you know what, I've got this restoration. We've got a 3-tooth cantilever and it works in my hands. And yeah, maybe it works in their hands. Maybe it worked for that specific patient. But there are a number of things you've got to look at. It could be patient specific. We've got to look at the materials. We've got to look at the opposing occlusion. We've got to look at prosthetic space. There's so many things we need to look at. Science on cantilever length is very cloudy and really doesn't, there's not a lot of useful information. And once again, when we don't have useful information, we have to exercise, common sense and biomechanical principles. We do know that the longer the cantilever, the less load to fracture. We do know that if the connector size is very small, where the cantilever is, there's a likelihood that we may get fracture. So guidelines, I would tell you, is as little distal cantilever as possible. I would also caution you to minimize the buccal cantilever. The reason for that is patients may come in, severe resorption, you're able to get the implants in there, and they want this big, wide smile. And the implants are more resorbed towards the palate. And now they want this big, wide smile, and now we've got this big buccal cantilever. And that can't be helpful to the implants. We do know that the framework should be thicker in the cantilever section, and we want to have a lighter occlusion on the cantilever section of the restorations. All right, now, unanswered questions, long term, in terms of satisfaction and cost. Now, what is the value in doing some pre-prosthetic surgery and doing sinus lift and adding additional implants? Not a bad idea. If you have a patient which is 25 and they're going to lose all of their teeth and they have pneumatized sinuses, maybe it's a good idea to do sinus lifts and place implants and have that extra, level of security. How much can you cantilever? Little as possible. And say the patient has rheumatized sinuses, and you cannot cantilever. There's nothing to prevent you from doing something with a shortened dental arch. Patient can have premolar to premolar, and we know definitely on natural teeth that the shortened dental arch works very, very well. So myth number 5, we have science for cantilever length. Unfortunately, we don't. Most of them are based on biomechanical principles and not science. Next myth, digital is better than analog. And today, I can tell you, I love digital dentistry. Our teaching institute is called the Digital Dentistry Institute. So we do utilize a lot of digital technologies, but we do teach analog first, because you need to know analog before you start using digital. One of the problems we have with digital is a lot of companies are promoting products and they're making us believe that it's so simple that anybody can do it. And we can print you a surgical guide and you just have to pick it up and put the implant in and everything will go according to clockwork and you're not going to have a problem. I beg to differ. I think digital technology is fantastic. Everybody should be using it in diagnosis and treatment planning. It gives you a lot of information. But as far as digital delivery is concerned, you have to master the analog principles before we go towards digital. So I'm going to run this video to illustrate that principle. Actually, I'm getting ahead of myself here. So when we start talking about digital dentistry per se, we can have digital at various levels. We can have digital for diagnosis and treatment planning. We can have digitally printed guides for surgical placement. We can have digital technology whereby we can literally mill the restoration, or we could have digital technology which will take you without a model all the way through to the definitive results. And different people use different aspects of digital technology. So digital technology is growing. We are not fully there yet as far as scanning implants or full arch restorations. Hopefully one day we will be. But digital technology definitely brings you an additional tool that you can use in diagnosing and treatment planning your patients. Now, this is one system that has been used. And essentially what it is, as far as diagnosis and treatment planning is concerned, we combine the CT, the model, and the company that provides you this instrumentation. They give you a surgical guide, a bone reduction guide, an abutment placement guide. They give you the provisional, and even literally the final restoration in a precursor format whereby you can take jaw relations and so forth. So this is digitally guided therapy, and this is the guide, the bone reduction guide. This is the abutment orientation guide. Implants are placed according to the guide. Abutments are oriented. And then we have the pickup, and this is the pickup for the provisional restoration. Temporary cylinders are placed and we can pick up the provisional restoration. And, obviously, seems like it's going well, but this was done in expert hands. And in my humble opinion, probably too much bone was removed, more than we would have liked. And a lot of these companies are producing these types of guides. And another thing, perpetuating a lot of bone removal when really this amount of bone removal is not necessary. But this is just to illustrate the procedure. And, does it have a place? It does. For me, digitally guided would be perfect in situations where you are doing a tooth only type of restoration where the precision of the implant placement is absolutely key. To illustrate my point in regards to digital versus analog, I'm going to run a short video for you. Hopefully it plays well.
Making smoothie. Calendar. No meetings today. Remember, dentist at 9:30. Fire off. Fire off. Open door. Door open. And we're going to do one more. Fire. Open door. Run voice command. Open door. Run voice command. Open. Open door. Repeat that. Open door. I didn't understand that. Hey, open door. Play on the floor. Play on the floor. Play on the floor. Open the door. Open control.
So that is my way of explaining digital versus analog. As I said, I think digital is a fantastic tool to make things, efficient. However, you have to master analog principles before getting into digital. For example, if your surgical guide for some reason does not fit your digitally fabricated surgical guide, what are you going to do? If something goes wrong, how are you going to fix it? So it's important to master the analog principles. Now let's talk about the realities of graftless solutions. And I'm going to illustrate it by showing you a patient that was treated. This is Tammy. Tammy came to see us in 2011, I believe. And she came in and she wanted a beautiful smile. She'd had some crowns which had been lost. She didn't like the contour of her crown. She really wanted something that she could be proud of. And this is how Tammy looked. And overall, not so bad. Few crowns missing here and there. The color of the crown not great. Some, I would say, bulky restorations. But overall, not so bad. And this was her panoramic radiograph. She'd had a couple of implants placed. She seemed to have good bone levels. And when we took periapical radiographs, long roots, really manageable teeth, So once again, we came to a diagnosis. We had caries, we had periodontal disease, we had some failing restorations, and then we had to make a treatment plan. And this presentation is on graftless solutions, and all on 4. So you're probably wondering, what's the treatment plan? And you're probably asking yourself, is he really going to remove all of her teeth and place implants? I will tell you no, I was not going to do that. And I'm going to say a strong no, because I see many of these patients where teeth have been removed. And unfortunately, I will tell you, our treatment plan for Tammy, before I get ahead of myself, was to do caries control, handle the perio, handle the endo, and it would have been a combination of crowns, veneers, and implant crowns, and then maintenance. And I'm fairly confident that we could have pulled off a result which she would have been happy with, and something which would have lasted her a significant period of time. Unfortunately, Tammy went to Texas, and in Texas, everything is bigger in Texas, right? And unfortunately, they convinced her to remove her teeth. They said, listen, the cost of doing all of these veneers and crowns and endo and what have you is going to be so much, and you're going to have problems with these later on along the line anyway, so why don't we just pull the teeth and place implants and just get this problem dealt with once and for all? When I look at this slide, I get quite disappointed. And I ask myself, are implants a replacement for teeth? Implants are not a replacement for teeth. Implants are a replacement for no teeth. Implants are a replacement for failing teeth, but implants are not a replacement for teeth. There's a subtle difference, and whenever we can keep teeth, we try to keep teeth. And when you look at this, it really hits home. And I see tons of these types of patients, and I sometimes wonder, why is this done? Why are patients' teeth removed in favor of implants when we can perfectly salvage them? So Tammy came back to see me was 2017. And she came in to see me like that. And I'm thinking to myself, what on earth happened here? And this was a provisional restoration. This was done by a prosthodontist out in Texas. And Tammy was just miserable. She wouldn't go out. She was, wouldn't socialize. Her husband came in to see me and he said, listen, you got to do something here. It just doesn't, she's just not herself anymore. She went in for a beautiful smile, was convinced to remove all of these teeth, and now she's stuck with this type of situation. So this is what Tammy presented with, and I'm sure you'll agree with me that even from a provisional perspective, they really don't look like teeth. And if you can look at the trajectory of the implants, they're very far forward, and this is conducive to provisionals breaking all the time. So imagine She went from this to this. How sad is that? She went from teeth which were perfectly savable. We could have created a beautiful smile. Now, don't just look at her teeth, look at her lip contours. Based on, the teeth position and what have you, it's impacted her whole facial profile. So I will tell you, graftless solutions, all on 4, all on 6, whatever you want to call it, it is a great treatment modality. It has a very high success rate, and we do a significant number of them when they're indicated. But keeping savable teeth, I promise you, is a lot better, So what do we do with Tammy now? Tammy comes in and we're stuck with the situation. The implants are in poor position. There are poor aesthetics. We've lost tooth, bone, and tissue. You can see we have a flat gingival profile. There's really no chance of us developing interproximal papilla here. And, are we going to need to use pink prosthetics? We're going to find that out. So what we do is we always go through this diagnostic checklist, and this is published in our text. And the first thing we do is we look at the incisal edge position. And in our opinion, there's strong contact with the lower lip. We want to try and decrease the incisal display. The smile line is very flat. We want to follow the contour of the lower lip. We want to try and decrease the vertical overlap. And we want to try and reestablish her face height. The next thing we look at is restorative space. Restorative space is based on the type of restoration you're going to do. Our goal here was to do a zirconia-based restoration. And for that, we didn't need as much space as acrylic resin titanium for sure. And as I mentioned previously in the presentation, we don't do acrylic resin titanium for maxillary restorations anymore. So we were going to do, the goal was to do what we call a zirconia-based restoration so that we really didn't have to remove bone. Lip support was adequate, maybe a little bit over-supported. The teeth look a little bit flared forward. And smile line and lip length, she did have a short lip, and we wanted the smile line to follow the, the contour of her lower lip. And, these are all the things, from a facially generated perspective, we are treatment planning as a whole. We're not just looking at the teeth, we're looking at her eyes, we're looking at her face, we're looking at her smile, we're looking at her lip dynamics. There are a number of things that we are taking into consideration. We then look at the contours and emergence. We have to fabricate a restoration and implant placement so that the restoration contours are ideal and we can clean them very, very well. Even in regards to any type of provisional restoration we do, we have to satisfy all the requirements of the provisional restoration. We have to develop the soft tissue contours so that we can have a definitive restorations which has not just aesthetics, but good biomechanics, good cleansability, and what have you. And then we look at the occlusion, and occlusion we've talked about previously in the presentation. So let's have a look at the sequence of treatment for Tammy. So first thing we did is we made impressions, jaw relation records, tooth try-in. We're going to do an immediate load restoration and then fabricate the definitive restorations. Unfortunately for Tammy, the existing implants that she had were in a non-restorable position. They were too flared forward. So we decided to remove those implants. And just to give you a rationale of why we did that is when we made impressions, jaw relation records, and we did the tooth try-in, as we are planning the provisional restorations to work out our problems, you can see the position of the implants, you can see the thickness of the soft tissue. Those implants were not in a position that we could position her teeth ideally. So what we did is we, based on that tooth setup, there's one implant on the patient's upper right. We're going to use that to stabilize the surgical guide. And we had our provisional restoration ready for the day of surgery. So we give all this information, for our surgeon so that we can have everything ready and be able to load the implants should the primary stability be adequate. So challenges in this particular case, definitely the emotional toll of telling Tammy, listen, you've just paid for these implants and now we're going to have to remove them. Obviously, she's worried about the aesthetics. She has some trust issues. Based on the scan, we have lack of width and we have to re-angle these implants. So there's a lot of things we need to consider. And although on the panoramic radiograph, this looks great, right? Everything looks really nice and parallel, but in reality, they are all flared forwards. And look at the width of the bone. The width of the bone is very thin. Do we get in there and do we block graft? Do we do all of these things? We made the decision that we could pull this off without grafting, and we decided to do that. So what we did is, the goal was to remove the implants. Based on our surgical guide, we're going to tilt the distal implant. I'm sure we could have placed implants a little bit further behind the most distal implant on the left, but the reason for the tilting was to get a longer implant, and we're going to come out in the first smaller position anyway. So really there wasn't, if we can get a longer implant in there, there's really no reason to place additional implants there. So the implants had to be placed based on the final tooth position. And because we are restoring at multi-unit abutment level, we have to take into account the height of the multi-unit abutment. So the implants have to be placed a little bit deeper so that our multi-unit abutments can be placed so that our restoration is at multi-unit abutment level. And we have sufficient transition zone that we can take care of it. So look at the existing implant position. Literally hardly any bone on the buccal aspect. So we're going to position that implant a little bit more palatally to get a better or more ideal tooth position. And we can choose, pre-angled abutments. Usually anterior maxilla, we utilize a 17-degree angled abutment. So this is Tammy's starting situation. We get to surgery. We remove the existing implants, and I know, some of you may look at this and say, you're removing implants, but really we had no choice. And if implants are getting in the way, to be honest with you, we treat them like, bad teeth getting in the way. We remove them in favor of additional implant placement. And you can see where my guide is in relation to where the implants used to be. So the surgeon places the implants. They place the implants a little bit more palatally. We use pre-angled abutments so that the trajectory of the implants are coming through the cingulum area of the anterior teeth. So the implants are placed appropriately. And you can see based on our surgical guide, surgically, it's been done relatively well. We suture it up, and now it's time to immediate load. And we have 5 implants now. Obviously, the requirements of primary stability have to be satisfied. We have to control the occlusal loads. We're going to design the occlusion so that occlusion is on the anterior aspect of the teeth. And we're going to do a direct pickup. Now, there are many ways to immediate load. I don't have time in the presentation today to go through that. But what we do is we are indexing the position of the implants. We are adding the temporary cylinders. The temporary cylinders are not going to interfere with seating of the restoration. We're going to do a lab conversion. That's the day of surgery, and this is 1 week post-op. And when you look at this, yes, it's not absolutely ideal. We have some areas of bulk, I would say on the upper right premolar area, but these are all areas that we can correct. But we're using this as a tool to be able to figure out all of our problems in the provisional before we get to the definitive restoration. Now, definitive restoration is going to be a minimally layered zirconia restoration. And when I go back to the immediate load provisional, when I put it in, I didn't really like it. So I plan to do another provisional just so that we can test the aesthetics a little bit better, get them a little bit more refined. So the final restoration was going to be a minimally layered zirconia. We were going to make the decision on pink prosthetics based on tooth length and width proportion. We're going to make sure that our connector size was appropriate for zirconia. And if we needed to improve the aesthetics in terms of the proportions, we also had that pink prosthetics to fall back on. So this is post-integration. You can see the tissue is flat, but it's healthy tissue. And unfortunately, we do not have an opportunity here to regenerate interproximal papilla. So once again, we make our impressions, we get the tooth position where we need to be, and we have a prototype to test the aesthetics and phonetics. So this is our second provisional restoration, just so that Tammy can go home, she can start smiling again, she can show her husband, and she can feel whole again. It's been such a long time that since she's been able to do this. So we're using pink ceramic to improve the proportions of the teeth. You can see from a width to length perspective, the width to length perspective is not so great. And, you know, really don't want to leave her with long teeth. So we decide that we're going to use pink ceramic. So we utilize pink ceramic to create an artificial papilla, and Tammy's happy. And this is, once again, it's minimally layered zirconia. All the occlusion and the guiding surfaces are in zirconia. Just the aesthetics are in, you know, minimally layered. So this restoration provides us cross-arch stabilization. We're trying to minimize the cantilever. We are minimizing the buccal lever arm and shallow cusp angle on posterior teeth. And this is how Tammy finishes up. Is it an ideal result? No, it's not an ideal result, but I think based on where we were to where we are right now, I think we did well. Now, when I look at this slide series, it saddens me because no matter how well we can do the ceramics, no matter how well we can do the pink tissue, nothing looks as nice as what the patient has, you know, the patient's existing teeth. So the story here, you look at the start situation, you look at the transition, you look at the final, and yes, Tammy is happy. Yes, Tammy is smiling again. You know, you look at her eyes and you can see she wants to live life again. But I look at the start situation and I think to myself, my goodness, those teeth could have been saved. And, you know, it's a shame that these teeth had to be removed. And one of the quotes which one of our colleagues had said, Mala Devan, he said, our goal should be the perpetual preservation of what remains rather than the meticulous restoration of what is missing. And this is something that we really do need to espouse to. And Dr. Pankey once said, if patients knew what you knew, they would want what you want. Let me just a second here. So with that said, I'm going to finish up here. And I want, you know, it's been an hour and a half and you probably heard my phone's ringing, and we're about to start patient treatment. So I want to thank you all for your time and attention. And, you know, hopefully we'll meet at some point. If you need any further information, please feel free to go to www.ddidental.com. And I look forward to meeting you soon. Thank you. So we have some questions here, all from the same person. And I'm just going to answer some of those questions so that you know. And it says, hi, it's all on 4 techniques. It is all on 4. We call it graftless. I don't like the word all on 4 because it pertains to using just 4 implants. And, you know, you saw some of the cases, which is not just 4 implants. We use sometimes 5, sometimes 6. The second question, I don't understand why we need to take off bone in the mandibular arch to put implants in. We addressed that question. I think removing a lot of bone unless you need to. The reason you'd remove bone is for hygienic contours, to improve the emergence profile, for the restorative material. So if you're using acrylic resin titanium, you need the space. And the last question is, are you going to get a replay of this webinar? I guess you're going to have to ask Paul Tipton. I assume you will. I'm sure they're recording it. So they're all the questions that we've answered. So with that said, I will hand it over back to Tipton Training. Thank you for your time and attention.
Hi there, Saj. There's one more question in chat from Robert Williams. Starts with amazing lecture. Can you see that?
I can't see it. What is it? Actually, let's have a look.
Okay, so do you want me, I'll read it to you. Okay, so amazing lecture and incredible results. Thank you, Saj. On the case with Tammy, in hindsight, could you have done slightly more of a alveoplasty to ensure her transition line was definitely hidden?
We could have, for sure. And we did show some papilla there. And yes, we could have raised it a little bit further up, but we wanted to be a little bit more conservative. And we tested that in, you know, provisional restoration, and she was accepting of it. And she wanted to show some, you know, some papilla to give it a more natural look. But yes, we could have done that.
Saj, there's just one more here as well. If you have a patient who you feel might struggle or be less likely to comply with immaculate oral hygiene around an FP1 bridge, could that be a justification to do bone reduction and give FP3, which is more easy to maintain?
All right, so I will tell you, if a patient doesn't have good oral hygiene, an FP1 or an FP3 gives you no advantages. The way we design either type of restoration is that we compress the tissue. So when these types of patients present, before we progress to removing all of their teeth and placing implants, believe it or not, they go through a lot of hygiene appointments first. And although we're going to remove their teeth, we want to get them used to the hygiene. I understand, the question with an FP3 type of restoration, you've got a flatter surface and less to keep clean. We have our patients, utilize water picks, and I really don't think the difference between an FP1 and an FP3 is going to make significant difference. I'd rather maintain more bone. Did that answer the question?
Saj, yes, thank you very much. That's all the questions answered. That was fantastic. Really enjoyed that. So thank you very much.
Thank you. You guys have a good afternoon.
Okay, have a brilliant day. I hope it's lovely and sunny in California.
Thank you. Take care.
Okay, take care. Enjoy your weekend, Saj. Bye-bye.
Bye-bye.